Good evening, Dr. Amita.
Good evening, ma'am. How are you?
Hi, how are you?
Good evening, everyone. Good evening, Dr. Amita.
Yeah.
Good evening.
Good evening to everyone.
Good evening.
Hello. ¿Me
Yes, sir, you're audible.
Muy bien.
I think we can start now. Shobha ma'am, can we?
Neeta ma'am, Dr. J. Arora, Dr. Shweta, they are still supposed to join.
Yeah, you can talk directly.
Dr. Neeta, can you hear Dr. Michael?
Yes, we can. We can.
Yeah.
Okay, good.
Hello, everybody. I think we start. Can you start the recording on Echo team?
Yes, ma'am, it's been recorded.
Yeah, thank you. If you can put up the slide, that will be great. Thank you. So, hello to everybody. Good afternoon and good evening and good morning to those of you who have joined in from across the globe. Today is our session 11 on a collaborative webinar series on advances in thalassemia care. So this webinar is being done with support from Thalassemia International Federation, Thalassemics India, and Eco India, who is our logistic partner. And this is a special webinar because we have been doing it. We are doing this session today on the occasion of International Thalassemia Day that's coming up on 8th of May. And this time we are doing it under the aegis of Pediatric Hematology Oncology Chapter of Indian Academy of Pediatrics. So from all at the Postgraduate Institute of Child Health, a warm welcome to this webinar. Now I request the advisor from Thalassemia International Federation, the medical advisor, Dr. Michael Angastinoitis, for his opening remarks.
Okay. Thank you very much, Dr. Nida. First of all, I would like to apologize for Dr. Eleftheriou. She had to leave at the last moment, but certainly this is a very important meeting. This is an era of new developments in thalassemia, new medications, and even the repurposing of old medications. So indeed, this should be of special interest to us all. I would like to introduce in particular Professor Nika Capellini, who is one of the greatest teachers in all aspects of thalassemia that I have known over the years. She's going to tell you about all these new drugs, but I hope that we will learn from you all about the repurposing, especially of thalidomide, how effective and how important. It is becoming as more and more patients in Asia are actually being treated by thalidomide. So thank you very much indeed, everybody.
Thank you, sir. So indeed, this is a very a topic which we have been planning for quite a while. And the initiative of the discussion about this topic came from, the initial discussion came from none other than Mrs. Shobha Tuli, who is the Secretary of Thalassemia India and a board member of Thalassemia International Federation. And Madam, kindly give your context for this topic, ma'am.
Good evening. Can you hear me?
Yes.
Okay. So, welcome to each one of you to session 11, which is on new and repurposed drugs in thalassemia. And this is a very special session, as Neeta has just mentioned, that we all know that on 8th of May is the World Thalassemia Day, which is being celebrated worldwide by more than 92 countries. And TIFF has been very supportive in giving slogans every year to all the thalassemia civil society people to follow it up. And I can say that living in one part of the world where the numbers are huge and the problem is very serious, that we all have been following up what has been given to us, not only just on paper, but also principally. So like Neeta said that, well, today's, topic is something very special, which we discussed about a few months back, and we thought that there could not be a better opportunity than on the World Thalassemia Day that this topic is discussed because there is a lot of curiosity among our patients and their families about the new drugs, and notably, especially, that luspatercept and thalidomide and maybe hydroxyurea and the future therapies like gene therapy. And I welcome Dr. Nika Capellini on behalf of Thalassemics India and Thalassemia International Federation, a great friend, but she is first my mentor from whom I learned thalassemia. And I'm very privileged of meeting her and in India as well as in other parts of the country wherever we went together for discussing thalassemia. We all know, and you will agree, that landscape of thalassemia treatment is rapidly shifting from chronic management towards disease modifying and curative therapies. So today's webinar will focus on new and repurposed drugs in thalassemia. Some of them are FDA approved, while others are approved for other conditions, but not for thalassemia. However, it is always good to discuss and bring to the table what is best for our patients and listen to the experts. So we have the experts from international expert like Nika, like I said, and then we have, you know it very well that we have Dr. Yadav, we have Dr. Jagdish Chandra, a very senior member. We have Shweta with Dr. Amita Mahajan, Dr. J.S. Arora, and of course our very own Dr. Neeta Radhakrishnan, who is going to moderate this session. So thank you very much once again, and thanks to ECO and thanks to IAP PHO for organizing this wonderful session. And I hope that deliberations will be very fruitful and we will go back after learning some new things and can of course share our ideas, on this platform. Over to Dr. Neeta, please.
Yeah, thank you, ma'am. So now we are doing this program in association with the Pediatric Hematology Oncology chapter. We have Dr. Shweta Bansal joined us. I would request Dr. Shweta to kindly introduce the topic for us.
Yeah, thanks, Neeta, for inviting me as a chairperson for this webinar. I think Mrs. Tuli has already told us that we are going to discuss about the new and repurposed drugs. And as we know, in thalassemia, we need to give best to our patients, and we need to find the ways where we can decrease the blood transfusion to these patients. So definitely this webinar is of special importance, where we can optimize the care of these patients by using the drugs in a better way, that repurposed drugs and the newer drugs, how we can use for these patients. So today we are going to learn about it. Over to you, Dr. Neeta.
Thank you, Dr. Shweta. Now it's my privilege to introduce Dr. Maria Domenica Capellini. She has been already as in she has been a teacher of teachers, and we have all grown up learning what she has taught us about thalassemia through talks as well as through her articles and guidelines. So she is an MD in internal medicine. Madam is from the University of Milan, Italy, and has been very active in the field of thalassemia hemoglobinopathies for over, I think, 40 to 50 years now. Professor Caplini has focused on the phenotypic expression of thalassemia intermedia and identified mechanisms underlying the thrombotic risk associated with the disease. And she has been a regular author for Thalassemia International Federation guidelines and has done a lot of path-breaking work in new drugs related to thalassemia as well. She is a member of multiple societies, including American Society as well as the Italian Society of Hematology. She's an honorary fellow of the Royal College of Physicians and American College of Physicians, and she's received a Sultan bin Khalifa International Thalassemia Award in the year 2015. So over to you, Madam. It's our privilege to have you on board today for this session, and we're eagerly looking forward to your talk.
Thank you very much, Anita, for this kind introduction. And I didn't deserve it. Thank you, Tova Shuli, for also the word that she said. We are a very good friend, and I'm very pleased to be here. And I thank you for this kind invitation. I would like to share my screen now.
Yes.
Can you see my screen?
Not yet.
We tried before and it was properly working, so you have to let me open it.
Sure. Take your time.
No, actually, I need to share my screen, and why is a condividi impostazioni? Can you allow me to share the screen? Because I think you have to allow me.
Ma'am, you already have the access. So there is an arrow button in the topmost of your...
Yeah.
Yeah,
And
click
they
on it, ma'am.
said, condividi, okay. I see the program, but I cannot see my screen.
Just now you shared it, I think.
Can you see? Can you see the screen?
Not yet, ma'am.
I don't know. Before was...
Ma'am, there is an arrow option in your laptop. I hope, is it visible for you?
Can you do for me?
No.
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 No, condividi schermo, ok.
Dr. Nita, do you have the Dr. Nika's presentation?
No, ma'am, if you could
we opened it before and it was properly working. I don't know what is now wrong, because actually we just tried. Condividi.
Sometimes can leave and rejoin, then it will work.
No, it has been working. Ma'am, can you click on the arrow option, ma'am?
I do. Okay.
So when you click on the arrow option, you will get two options. One is through allow through the entire screen or the application windows. Are you able to see those options?
Condividi.
Yes. Oh, okay.
Okay.
Yes.
Okay.
Now just open
your screen is visible now.
Yes, perfect.
You can see it?
Yes, ma'am.
Okay,
Yes.
so I apologize for that. Was something changed. I was asked to talk about new drug in thalassemia, and I will mainly focus on those who are officially available or in progress to be available, and I leave the discussion for the repurposing drug to the other presentation, because you have the best experience in India. These are my disclosure. Just to start, I remind that the current therapeutic approaches for the management of thalassemia are the blood transfusion and iron chelation therapy. Of course, we have also some curative treatment such as gene therapy and bone marrow transplantation, but is not a part of this presentation. Although we improve along the last 30 years the red blood transfusion program and iron chelation therapy, and this improvement allowed a progression on patient survival, reaching the fourth, fifth decade and over. Nevertheless, there are definitely some unmet medical needs, which are mainly focused on improving the quality of life of the patients. And improving quality of life of thalassemia patients means to prevent or ameliorate comorbidities. And this goes through an effective management of the chronic anemia. It's definitely clear. It has been shown that increasing the hemoglobin levels goes with better survival, better quality of life, and particularly less comorbidities. I don't go in these details, but several papers have been published supporting that increasing hemoglobin is, at the end of the day, the most important target for thalassemia treatment. And how can we achieve this outcome without transfusion or reducing transfusion? Well, the first drug officially approved for treating the anemia in adult patients with transfusion-dependent thalassemia, and even for non-transfusion-dependent thalassemia, is luspatercept, which is an erythroid maturation agent. I don't go into details of mechanism of action of luspatercept in thalassemia. What I want to underline is that this compound is an erythroid maturation agent that traps selected TGF-beta superfamily ligands, and through this mechanism is enhancing the late stage of erythropoiesis. As you can see in this cartoon on your right part of the first scheme, you see that luspatercept binding and sequestering this selected ligand of TGF-beta reduces this SMAD2, SMAD3 signaling and promote the late stage maturation. Of course, you can immediately understand the clinical benefit in terms of increasing hemoglobin and red cells. Luspatercept has been approved in 2019 by FDA and in 2020 by EMA. EMA also approved in 2023 the use of luspatercept in non-transfusion dependent beta thalassemia, but this is not yet really available in many countries due to the reimbursement procedure. I just summarize in a single slide, because I'm sure all of you know, the result of the BELIEVE trial, the phase 3 trial, which prompted the registration of luspatercept in transfusion-dependent patients. And you can see that the primary and secondary endpoint were statistically achieved. The primary endpoint was the reduction of equal or more than 33% of transfusion burden compared to baseline. And for secondary endpoint, there were several endpoints, but mainly the decrease of more than 50%. Looking at this endpoint at any 12-week interval during the core treatment, you see that approximately 77% of the patients achieved this primary endpoint, and 50% approximately achieve it 50% reduction. But now luspatercept is available in real life, and I want to focus mainly on real life data because this is what physician has to know, patient has to know, and how it has to be prescribed in real life. So what are the objectives to evaluate in real life using luspatercept? First of all, we said we want to reduce the unit of blood transfused, and this has to imply a decrease in iron intake. We want to reduce the hospital visit, and that means to change the transfusion interval. We want to increase the pre-transfusional hemoglobin, and we want to reduce the number of transfused unit or the volume of blood unit. So these aims should be adapted patients by patients to discuss with the patients, but they are mainly the objective which has to be considered in real life. In a paper published a couple of years ago by Khaled Musalam and other experts, we try to define a prioritization of the patients for luspatercept treatment, again, to be used in real life. And the priority is mainly given to patients unable to sustain transfusion regimen for the target hemoglobin expected. This could be for shortage of blood, problem of difficulties in adhering to the scheme of transfusion, and so on. The second group of patients who deserve to be treated with luspatercept are patients who have maybe some challenging in adhering to the transfusion schedule, but they may mainly have difficult to control the iron burden. And last, we may consider any patients on regular blood transfusion adherent to a treatment, but they may, by choice, prefer to move to an alternative treatment. And we also try to identify the criteria for defining the response to treatment as excellent, good, or satisfactory. Just to be practical, I want to show you some data from our experience in Milan in real life. These are data from 48 patients who received the treatment for at least 12 weeks, but now they are much more. In the table, you can have a comparison between data from this real-life cohort and the BELIEVE cohort, and you see that our patients in real life are older than those on the BELIEVE, less splenectomized, and they were probably more heavily transfused. However, the response is absolutely similar to that observed in the clinical trial, so it was very satisfactory. 79% of the patients achieve the reduction of more than 50% during a fixed period, or 65% achieve the same results at any 12 weeks. And this is just an example showing how the pre-hemoglobin goes up from 8.2 to 9.1 from week 24 pre-treatment to week 25 after treatment. So let's say that the way of response in real life is very similar and satisfactory as it was in the trial. And for safety, nothing different was observed. The other large Italian cohort treated with luspatercept has been very recently published by Origa in American Journal of Hematology. It includes more than 230 patients, and the evaluation of response is here summarized according to the criteria of response published by Khaled Musalam. And you see that 15.5% had of the 230 patients treated had an excellent response. And we say excellent means persistent reduction of more than 50% in transfusion requirement within 6 months of therapy. 44% had a good response, which means a reduction of equal or more than 33%. 23 were satisfactory with any reduction in transfusion requirement without achieving 33%, and 18 had no efficacy. And looking at the univariate logistic regression for patients classified as good or excellent responder, the parameters evaluated were splenectomy, age at therapy, age at diagnosis, and age at first transfusion, and they seem to be significantly associated with the response. There were also some patients that temporarily or permanently discontinued treatment during the treatment. But there were also some discontinuation. And what are the main reasons of discontinuation in real life? Approximately 1/4 of discontinuation was due to a patient judgment for insufficient efficacy. 1/4 was a physician judgment for insufficient efficacy, and the other two were adverse event, but it's difficult actually to attribute this adverse event to the treatment or to other, let's say, common adverse event which are observed a long time in thalassemia patients. So this is the state of art for luspatercept. I didn't mention the NTDT results, which were quite good also in the Beyond study, because in NTDT is much less used in real life. Moving to another new drug, which has been approved for the treatment of anemia in adult patients, and in this case is either alpha and beta, transfusion dependent and non-transfusion dependent, is mitapivat. Mitapivat is a PK activator, is an oral allosteric activator of pyruvate kinase, and that restores the red blood cell energy metabolism, and in this way improve the metabolism of red cells. So the thalassemic red cells improve their quality because there is an increase, more ATP is available, so more energy is available for the red cells. And also in this case, there are several clinical benefits and mainly improving the quality of the red cells is not only the survival, is not only the ineffective erythropoiesis, but there is a reduction in hemolysis. So red cells, which are fragile, the thalassemic red cells are fragile, they improve significantly. What is the state of art for mitapivat? Two global phase 3 randomized placebo-controlled trials were established for NTDT and TDT. Again, I want to underline that alpha thalassemia are included. So quickly, because again, I'm sure you know the data, I will present the results for the Energize T. Energize T is the trial in adult transfusion-dependent patients. And even for this trial, the primary endpoint was the transfusion burden reduction. And in this case, the primary endpoint was a reduction of equal or more than 50% in any consecutive 12-week period through a core period, which was 48 weeks. And you can see that patients who achieve this primary endpoint were 34% for those in mitapivat. And also the secondary endpoint, which are listed here, but I'm not going to mention all based on reduction of transfusion burden, were statistically achieved. And definitely there was now data are more than those I'm presenting, because the many other patients completed the study. But anyway, at higher proportion of patients in the mitapivat group achieve the transfusion independence, defined as a transfusion-free time for more than 8 consecutive weeks through the core period. And you can see here that 17 patients were transfusion-free, and among them, 7 were still transfusion independent at the evaluation time. For adverse event, nothing particular was observed, nothing that was, let's say, responsible for stopping the treatment. So in conclusion, the Energize 3 trial showed that mitapivat was effective and resulted in significant reduction in transfusion burden in a globally representative population of patients with TDT, including alpha. The results, the paper has been accepted last week in Lancet and will be presented. For this drug, I want also to mention the NTDT, because has been approved either by FDA and EMA, and the primary endpoint for NTDT was the increase of hemoglobin of at least 1 gram compared to baseline. And you can see here that there was a significantly higher hemoglobin response in treated patients compared to placebo. And you see that the average hemoglobin concentration increase from week 12 to week 24 was even 1.6 gram per deciliter. And the other important observation was the improvement on FACIT fatigue score, because that is a kind of measure of efficacy in non-transfusion dependent thalassemia patients, and definitely there was an improve on that. Quickly, these are the graph showing the results, showing the change of hemoglobin concentration, which I already mentioned, but also what is important, as I mentioned, for the mechanism of mitapivat, the reduction in hemolysis parameters and in marker of ineffective erythropoiesis compared to placebo. And one important point in non-transfused patient is the improvement in 6-minute walk, which was observed in treated patients compared to placebo. There was an increase in the 6-minute walk, which was clinically important compared to what reported from the literature. Similar adverse event than in TDT. So even in the Energize showed the efficacy with significant improvement in anemia and fatigue in alpha and beta non-transfusion. Is that all? No, there are other PK activator. One is etavopivat, which has been also approved for treatment, but the regular status is still not completed. The mechanism of action are exactly similar to that of mitapivat. The only difference probably is that etavopivat is specific for PKR, so for one subtype of PK, which is stabilizing the etavopivat stabilize the active form of PKR. I didn't mention, even talking of mitapivat, that these are oral drugs given twice a day, but are oral. The results from the key study showed that for NTDT there is an improvement of hemoglobin more than 1.4 gram per deciliter with a reduction of bilirubin, and for TDT there was a significant reduction in transfusion burden. This slide is just a comparison of the three new drugs, of whom luspatercept, all are approved, but luspatercept is definitely in the market since quite a long time, more than 5 years now, and we have a large body of data in real life. Mitapivat and etavopivat hopefully will start to be used more widely in the coming weeks or months. There are some other compounds, stimulator inducer of fetal hemoglobin, but they are in early trials and they are not yet we don't have yet any results. So with that, I stop in relating to the new drug known for clinical trials and approved or on approval. But then, as it was mentioned by Shobatuli and Nita, there are other compounds which are now repositioned for treating anemia in thalassemia, such as thalidomide, and I'm also looking forward to listen the experience from India on these compounds. And I thank you very much for your attention.
Thank you, Dr. Capellini. I'm Dr. Shweta here, and it was a wonderful, outstanding talk, I must say. And you have described the new and repurposed drugs in thalassemia in a very beautiful manner, and it carries a lot of clarity in presenting the evolving therapeutic strategies, and it is truly valuable for us. There is a question for you from the audience. Which is better, luspatercept or mitapivat? And how you decide in which patient what to give?
What is better? They have two different mechanisms of action. One, as I mentioned, is inducing effective erythropoiesis through the late erythroid maturation. The other one is improving the red metabolism, so the thalassemic red metabolism. So they have two different mechanisms of action, and both based on clinical trials and for luspatercept also real life showed a good improvement of hemoglobin, reducing blood transfusion on one side or increasing hemoglobin. So both may be useful and efficacious for treating the patient. I am looking to get more information on real life for mitapivat, but my attitude is to discuss, first of all, of the patients, also because the way of administration is different. Luspatercept implies a subcutaneous infusion every 3 weeks. The other one is an oral drug. So I discuss with the patients the two options. For luspatercept, I now have some restriction based on experience for patients who had extensive extramedullary hematopoiesis masses. Because in such a case, although I'm not worried on serious consequences, but in such cases, you may have initially an expansion of these masses. Then they, let's say, stabilize, but at the beginning, and they may cause some clinical troubles. The other point is risk of thrombosis. On that, I'm very confident for luspatercept. I start anticoagulate patient in case, but it's not an exclusion. Mitapivat so far have no restriction.
Okay. Yeah. Thank you so much. I think it was very clear and can help us in like deciding which patients to be given what, or maybe at least we should discuss with the families how to start and
Exactly.
from where to start. Yeah. So we thank you for such wonderful insights. And next we are going to have a panel discussion on the same topic. Our moderator is Dr. Neeta Radhakrishna. I don't think so she requires any introduction. Just for this thing, I would like to tell that Dr. Neeta Radhakrishna is a prominent and leading pediatric hemato-oncologist in our country, and she is the head of the Department of Pediatric Hem-Onc and BMT in Noida, PGICH, Noida Hospital. And with this, Dr. Capellini, I would request you to stay as a panelist over here, and I would introduce other panelists. So we have
Definitely, I will stay till the end.
Thank you so much. Thank you so much. So the other panelists, we have our esteemed panelist, Dr. Jagdish Chandra sir. He is a previous director of Lady Hardinge Medical College and head of pediatrics. He served as chair of INPOC Red Cell Subcommittee also from 2021 to 2023. Welcome, sir. Please join the panel. Then we have Dr. Amita Mahajan, ma'am. She is a senior consultant and head pediatric hemato-oncology at Apollo New Delhi, and she is an advisor for Thalassemia India. Next, we have Dr. G.S. Arora. He is General Secretary of National Thalassemia Welfare Society and Federation of Indian Thalassemia. Over to you, Anita, to have a wonderful discussion on these drugs. Thank you so much.
Thank you, Dr. Shweta. And I would like to invite the esteemed panelists to this very, very practical discussion that will, I hopefully continue after those wonderful insights from Professor Capellini. So we are going to be discussing drugs that are being used in patients with thalassemia and the drugs which have a lot of promise going ahead. So I've started with hydroxyurea just because it is still being used in our country. And I would request experts to suggest how we should be using hydroxyurea in patients with thalassemia. So currently, I think most centers would be giving a trial of hydroxyurea for all non-transfusion dependent patients. It is definitely a drug which should be used in hemoglobin SS as well as S beta thalassemia. And in E beta also, all patients generally will receive a trial of hydroxyurea. But although we are to stop this, if we do not have a benefit, I've seen that it continues many a times. A low dose hydroxyurea keeps getting used. So I'll start with you, Professor Capellini. If you have a child in Italy currently in your practice, when you have patients coming with non-transfusion dependent, is this still a drug which is used, or is it completely because there are a lot of safety concerns around hydroxyurea from the patient community, and we have patients joined in today, parents and family members as well. So in your practice, do you give a trial of hydroxyurea for all patients with non-transfusion dependent thalassemia? Ma'am, you are muted. Yeah.
No, my answer is no. We are not using hydroxyurea in non-transfusion dependent thalassemia patient as regular treatment because actually years ago, after the results published by the Iranian physician, we said, let's try, and I start to treat some patients, but without benefit. So we didn't see any benefit. So I'm not treating as a choice patients or children with anti-DT and hydroxyurea. However, I use and I recommend to use hydroxyurea in patients who have anti-DT patients who have extramedullary hematopoiesis masses, especially if they cause symptoms. I experience few patients, 3-4 patients who came in with paresthesia due to paralumbar masses. I start immediately hydroxyurea associated with some transfusion, but particularly hydroxyurea, and they recovered from paresthesia or paraplegia even. Why that? I mean, my interpretation is that hydroxyurea is pushing down the activity of these extramedullary hematopoiesis masses, and then is relieving from the symptoms. But I'm not using it as a treatment.
Thank you very much, ma'am, for clarifying that. So Jagdish Chandra, sir.
Yes.
I didn't see you pin, sir. So in your practice, transfusion dependent. So often we do see patients who come in who are even transfusion dependent, even E beta as well as beta thal patients who are being continued on hydroxyurea. So do you, what is your advice? One. And point number two, are there any subsets of TDT where you would want to give a trial of hydroxyurea?
Thank you for that question. Yeah, actually, hydroxyurea has in anti-DT a large number of patients in our country and other developing countries they are receiving. Unlike what Madam described, that there it is not a a standard of care. In our country, mostly it is kind of a standard of care for anti-DT. But for TDT, the literature whatever is available now, the large body of literature says that a subset of patients do respond. A very recent meta-analysis, which is published, I think, just about 7, 8 months back, it showed that nearly a third of Indian patients responded to the hydroxyurea by decreasing the transfusion requirement. So, and we know that HBE beta thalassemia, when it has a TDT phenotype, clinical phenotype of TDT, and those with XMN1 polymorphism, they do have some better chances of response to hydroxyurea compared to the other ones. So, in some cases where they are not able to maintain the hemoglobin in the desired range, and we can check their profile. These are the conditions when we can prescribe hydroxyurea in patient with TDT. So there is a subset of patients which will respond to the use of hydroxyurea.
So if cost is not a constraint, would you recommend that TDT patients be tested for XMN1, or would you do it only in the milder phenotypes? Even TDT would have a group of patients who are not so much frequent.
Yeah, I think it may not be a routine, but just in case it's we are considering that hydroxyurea might help these patients. So in that situation, one can advise doing it in the testing for XMN polymorphism.
Thank you, sir. Dr. Amita Mahajan, ma'am. So if we are starting hydroxyurea in any of these subsets of patients, how long do you wait for the response, and when are we supposed to stop it?
So if we are giving a trial and it's mostly in NTDT, I would use it in TDT again in the situation of extramedullary hematopoiesis or even massive splenomegaly where it can achieve as, modest reduction in the splenic size. But in NTDT, we would start at around 10 mg per kg and we would assess for response at 3 and 6 months. And if by 6 months, I do not see a response, then I don't think we would continue. But I think our response assessment is also a little flawed. So hemoglobin is one of the measures. And definitely if it raises the hemoglobin by 1, like for any other drug, we would consider that as a significant response. But we are in a catch-22 situation because lots of patients report improvement in quality of life. So it may be because of reduction in extramedullary hematopoiesis. And I didn't think we really understand how hydroxyurea works because I'm sure there is mechanisms beyond HbF induction that are at play here. So I think it's just in totality in discussion with the patients. If we do, demonstrate a significant improvement in hemoglobin, and we do actually in our population see that in more than 50% of patients. But beyond that also, if there is reduction in the extramedullary hematopoiesis or the patients report improvement in quality of life, we may consider for longer. But at 6 months, I think it is enough time for us to assess formally whether we want to continue this endlessly or call it a day.
Thank you, ma'am, for that clear recommendation.
Great.
And finally, Professor Capellini, would you like to comment?
I totally agree with Dr. Ramida. That is the way to proceed. Yeah.
Thank you. And so now all decisions are made with patients and people with lived experience in the room. So I would like to request Dr. J.S. Arora. He is the General Secretary for National Thalassemia Welfare Society. So, sir, in your as part of a patient organization, how do you counsel families regarding the long-term effects and what there may be concerns regarding fertility, etc.? So, how would you counsel, sir?
Thank you, Dr. Neeta. Actually, hydroxyurea significantly reduces that sperm concentration and total sperm count, that is oligospermia and azoospermia. And it also has indicated that the decrease in even AMH, anti-Mullerian hormone. So means reduction of oocyte as well. So if at all a patient is taking hydroxyurea, if it is possible, then we may ask for a sperm and oocyte preservation for that. But usually this doesn't happen because patient is already taking when the child is, say, young, around 10, 12 years old. There is an increased risk of, you can say, during pregnancy to the fetus. So if at all the patient is taking hydroxyurea, we usually ask them to stop for preferably 6 months before the pregnancy. So that is another indication. And it may, as well as other side effects concerned, it may cause even leg ulcers or pigmentation, or you can say, and so during hydroxyurea, we also advise them to go for this double contraception, means barrier plus some other. So that is also advised to all the patients who are taking on the this hydroxyurea. And moreover, whenever the patients are taking hydroxyurea, we always advise them to go for repeatedly, at least once in 4 weeks or 6 weeks for CBC. So TLC, DLC platelet count, so that it may cause cytopenia, and in some cases maybe liver enzymes may be raised. So that is a concern regarding the toxicity and the fertility patient.
Thank you, sir. Now we go on to the next drug, which is probably much most awaited among the drugs which are being repurposed, is thalidomide. So in Indian scenario, just to brief you, Professor Capellini, that it's being used, probably the use came in around, I would say around 6 to 10 years. It's been used in multiple small groups. The trials, there were 2 clinical trials as far as I know. One is Professor Jagdish Chandra is the first author, and another one also led by Dr. Chandra, which were investigator-initiated clinical trials. This is a drug I don't think any company would be interested, because it's not, it is being used mainly in adult hematology settings and currently. So multiple centers after that in India have shared their experience. It is definitely helping a subset of patients. Their growth, I just put out the growth of a boy who's on thalidomide for the last few years, and you can see how it has shot up. But there are a lot of variability. There's a lot of variability in the prescription practices. A lot of people use it along with other drugs and so on. And the age as well. So there is nothing really specific, as in there is nothing there is no cutoff age that is prescribed. It's not approved for this use as well. So I'll start with you, ma'am. In global practice, so we all saw the position paper which came from TIFF in 25. So do you what is your position currently on using thalidomide especially in resource poor countries where access to the new drugs like luspatercept or mitapivat is going to be a very serious challenge?
This is a very interesting question. As you probably know, and Dr. Agostiniotis, if is still there, may add something on that. As you probably know, few months ago, actually a couple of months ago, TIFF established a board of experts to discuss the thalidomide use and to implement clinical trial to try to achieve a point for repositioning thalidomide on treatment. So at this point, to my knowledge, we are at this stage trying to collect as much data as possible and try to identify the let's say criteria of response, because as you mentioned, there is a huge heterogeneity on prescribing, a huge heterogeneity on response. So far it's quite difficult to say, okay, thalidomide can be used because it induces increase hemoglobin, reducing blood transfusion, blah, blah, blah. We don't have enough data on that. To my knowledge, the idea of TIFF is to design a proper clinical trial in order to get results to be presented to the official authority, because so far, in any I don't know how you are prescribing it in India, but if I have to prescribe thalidomide to a thalassemia patients, I have to follow a kind of rules, because it's an off-label drug, so we cannot prescribe it. This is, to my knowledge, the state of art. I look at the data because they've been presented at ASCAT and other occasion, and of course are quite consistent and encouraging. So I really want to know what is your personal opinion in India, how you feel on it.
Thank you, ma'am. Yes, we agree that it is something which has to be done in a research setting currently, because it's not at all, there is no approval as yet, even in our country. So, Chandra sir, in a patient who is coming to us, I think, and it's more than what we are practicing, it's more of what we see it's being prescribed. So, where would you consider a thalidomide in current scenario? Patients who are NTDT, who are coming in with recurrent severe anemia due to alloimmunization, hypersplenism, those kind of group, or TDT with a high transfusion burden, and despite everything, your chelation just goes through the roof. You don't have any much options to give. Where would you consider this drug? So you are muted, sir.
Yeah, thank you. Actually, Madam has described the concerns that TIFF has, and I think myself, Dr. Amita, and probably you were also there in those discussions regarding the thalidomide, whether what should be the position. In fact, uh, from our country, we were not pushing very much for the use of thalidomide. We were just wanting to know what is the stand of TIFF. On the other hand, we had presenters from Pakistan, where probably the availability of blood is even not as good as it is in our country. So they were wanting that this drug should become, available for the use of, for probably there also there are two sets of people, one for thalidomide, the other. So my stand is that there is no doubt in my mind about the efficacy of this drug as far as reducing the transfusion requirement is concerned. In the first study that I did on just about 35 patients, the transfusion requirement went down by more than 50% in nearly half of the patients. And another 25% had 25 to 50% reduction. So that's comparable to the other drugs which are being tested to reduce the transfusion requirement. The main problem is regarding the safety of the drug. So for that reason, till we have a, as it is being suggested that we should have a randomized control trial and then see where do we stand. So, and then the safety again has come, one question has come up regarding the cancer occurring more often in patients who receive thalidomide. So it has to be limited only in the probably in a study form or research settings. If we cannot left-right prescribe thalidomide for the treatment of thalassemia. So as you said yourself, those who are having problems in maintaining hemoglobin, either because of the red cell isoaluminization or severe hyperespism, or there is a problem in getting the blood, these are the candidates where it can be considered. And again, going what Dr. Arora described for hydroxyurea, here it would be even more important to counsel the patients regarding the problems with the drug and what could be the advantages versus the risk of the drug. So that is what my stand would be. Thank you.
And thank you also for highlighting that it should be done on a research basis with very good consenting with
Yeah, that's right.
the family. Yes, sir.
Not under 12 years of age, because till now for other indications also FDA approval is only for 12 years and above. And therefore, in our study also, both the studies in India that we did, where you were also part, Dr. Amita was also part of that study, Dr. Roda also was part of that study. So it was, we took patients about 12 years of age.
Thank you, sir. Because I think recently there was a concern that even small children were being put on this drug. So Amita ma'am, at what dose and how do you escalate? How do you de-escalate if you're starting?
So, Neeta, the big challenge is also about the dose, because there is no dose, specified anywhere for this indication. So, in the study, that multicentric study that Dr. Chandra was referring to, and he was the PI for that study, It had been our impression based on whatever literature is available that the response seems to be idiosyncratic rather than dose dependent. But we specifically looked at doses of 1 mg per kg versus 2 mg per kg. And we found that there was no difference in the response rate. So again, we are beyond the clinical trial setting. We are only prescribing it in the difficult situation scenario where there are limited options and there are lots of challenges. So we are currently not exceeding 1 mg per kg. In fact, even for an adult, we are not exceeding the 50 mg tablet. The tablet, the lowest strength is 50 mg. And in fact, if the patient documents a response, we begin, so there is no escalation. We don't go beyond 50 mg. And we, in fact, try to de-escalate either by giving it alternate days or skipping a few days a week, or if the family can manage to do that, to make it into smaller capsules. And in my experience, the very good responders actually seem to retain their benefit even at much significantly lower doses. So we cannot predict response at this moment. It's a question of giving a trial. And again, most patients who are going to respond demonstrate a response by 12 weeks. And very few be between 12 and 24 weeks. So again, if we were to try this drug in a difficult situation, we must again conclude or have a reassessment at 12 and 24 weeks, and not to exceed beyond a 50 mg even for an adult weight. And for significant responders, we do a de-escalation strategy and will continue them on the lowest dose that continues to give them maintain their response. And for some, it is just 2 tablets a week. So that is, that's been very interesting experience or learning curve for us.
So, Nita, just one point here regarding this study, what we are discussing. We had some 185 patients, and we are now close to 5.5 years that we started, and we are following them up. Not, we have not come across any case of malignancy in this set of patients, and neither in the set of patients that we treated sometime in 2019. So 19 later half we started, and early 2020 we completed that 6 months study, the initial 35 patients. So in those 225 patients over a period of 5.5 years or so follow up, we have not encountered any patient developing any malignancy.
That is reassuring, sir.
And the other adverse effects which have been seen, the grade 3 or 4 adverse effects are much less compared to what we have with other drugs which are being tried to reduce the transfusion needs.
Thank you, sir.
May I ask a question?
Yes, ma'am.
Yes, ma'am.
Do you have any explanation for the maintenance of response when you reduce the dose? Because as Amita said, you start with higher dose and then you can de-escalate and they maintain the response, which is extremely interesting. Do you have an explanation of that?
So actually, the drug will not have a washout immediately when it is stopped. So what we were trying to do was that after 7 days, when we were giving daily, so we tried reducing it, say, 1 day off, 6 days a week, then 5 days a week, and then 4 days a week. So till 4 days a week, this continued to show response. And our explanation at this time is that probably the effect that it leads to the ineffective erythropoiesis is improving by the levels of cytokines. They probably will be maintained till few days after the drug has been taken off. Yeah. So as Dr. Amita said, that one could start with say 1 milligram and then going on to alternate day. That could have been a very good idea to again try this form of treatment, or those who respond switch over to alternate day and see that how much we can maintain with that. Yeah.
Thank you, sir.
Very interesting.
I think we also discussed during our trial as well that there may be some biological modifiers for this, which are if causing this drug to work. And so for those patients with those modifiers, maybe the drug is not required in a very big dose. It is very small doses might be sensitive as well. But we never got around testing those modifiers for funding it.
Yes.
That's
But
something
there is data from China that, there seem to be certain genotypes or certain specific mutations that can predict thalidomide sensitivity. So I think it is probably again down to that molecular basis, but we are just currently doing it on clinical trial basis.
Yeah, and that's true probably even for hydroxyurea.
Absolutely.
Because our patients, they don't respond as your patients do. I'm sure there is a difference, and probably some genes not globin related outside the globin cluster. So still we have to learn the pharmacogenetics, genomics on that.
True, ma'am. So, Dr. Arora, sir.
Can I come in, Dr. Neeta?
Yes, ma'am.
Can I come in here?
Yes, please, ma'am.
Because when you're talking about thalidomide, so my question to Dr., not only question, it's a comment to Dr. Jagdish Chandraji, that, what we have found it that sometimes the parents, we inform them that, well, it is not approved, this medicine, and what you have seen also, and you also know that this drug is being used, in various parts of our country by a lot of patients, as you have very rightly said. So at the same time, that we are saying that it should be used under the research settings and all that. So even after counseling, what is your suggestion that they do not listen to the medical advice and still they would say that, well, they want to use this medicine. So what kind of what stand we should actually, we should take it. This is for the civil society people to understand, because they are the ones who come to us for counseling sometimes before going to the doctors. So what stand we should actually take and tell them and advise them?
Actually, this is a very tricky situation. Actually, what patients do is whenever they see that some patients are getting benefited, so why should I not? I should not take, and they start taking. And if they have response, and after that, if we come in and we advise that, look, there could be some issues, and it is not approved for this indication. So I really can't say what to do with that kind of situation. I mean, we can, when we are starting, we can at least tell them that these are the problems. This drug is not approved. This is effective, fine. We are trying to, still study on this drug, and the dose that we need to give, the dose when we need to reduce, and how to monitor everything is being done. So other than that, I don't know how can we just stop from taking. This drug is it's available over the counter. It's not in our country, it's not a prescription drug. So they can procure and they can continue giving.
Thank you, doctor.
True, ma'am. Very valid point. So a lot of parents, even with the big hepatosplenomegaly, with short stature, still are so happy to take the drug just because they don't have to transfuse. It's completely pointless, but it's very difficult. Like you said, after they start and they feel that there is transfusion is not required, they feel the drug is good. So I think we had a question from the civil society only. We had a question to Dr. Arora on this topic itself as to how do we counsel families. So I think we'll take this question first, sir.
I think my question to this question is relevant to all the previous three panelists, but they said it. See, it is in two parts. You can say lack of response and the toxicity. As far as response and toxicity is concerned, I think toxicity is more important to stop the drug than looking for the response. So first of all, my primary concern is to look for the toxicity. So I'll talk about toxicity later. First, coming to response. So we'll wait again, as Dr. Amita Manu said, 3 to 6 months. If by 3 months there is no response, we can still think of escalating the dose and think over it. And but if there is no response after 6 months, I usually stop the treatment. I start the treatment with 0.5 milligram per kg body weight with or without hydroxyurea. Most of our patients are also taking in combination with hydroxyurea, and the response has been very good. And most of them, even say, I can say more than 70%, maybe more, patients are off transfusions. But before starting, I tell them each and every this side effect, not only just constipation, numbness, all these things, including the malignancy, which we have been recently discussing that. And even before giving that, we have this prescribed consent form, and at least the patient and adult member of the family must read it, right, and understand it, then sign it. Only then I started, otherwise don't start it. The second part was those who are already taking. Yes, it's very difficult to ask them to stop it. So if even those who are taking for so many years, again we tell them these are the side effects. Now you have to think whether you want it or not. And it's the same, but I told you about hydroxyurea. Because they should not go for any pregnancy. If at all they are being married or going for pregnancy, they should stop it at least 6 months before that. And this regarding toxicity, to my patients, those even those who are not from Delhi or they're outside, I take the reports every 3 to 4 weeks with CBC, SGOT, SGPT, bilirubin, urea, creatinine. I'm very particular about that. If I don't get report, I don't give medicine, I don't give prescription. That is, I'm very strong. And another question is that is of the thrombosis. Even one person asked as well. So with every thalidomide, we add aspirin, though we did not add in our trial, but I am giving aspirin to each and every patient the day the patient is taking the thalidomide. So, I would like to reiterate that the toxicity is more important to stop the treatment than looking at the response.
Thank you, sir. Sir mentioned contraception, ma'am. In adolescent girls, how do you counsel them, Dr. Amita, ma'am?
So, firstly, I think adolescent girls, we would generally just completely avoid it. Or girls in the reproductive, we are usually using it only in crisis situations. So it would be very unusual for us to be giving this to an adult. Like even in our trial, you know that just right after enrollment, a young girl got married. So we took her off the study immediately because, that's our, kind of on the ground policy. But if somebody were for some indication really needs the trial of thalidomide, again, the standard, this thing that they have to use double contraception. And we would document that this has been advised for the trial. We had included also that they will do, a pregnancy test at every visit. But, for in our social circumstances in India, for unmarried girls, for us to ask pregnancy test each visit, that's not going to be practical. So we would try to avoid it and otherwise counsel them very aggressively that is the number one toxic side effect is the teratogenicity. So they need to be practicing double contraception and to document it as extensively as possible that all this has been conveyed to the family.
Thank you, ma'am.
So I think regarding this, this is important even for the boys, not taking it in the.
And sir, final question to you regarding thalidomide. There is a lot of prescription that goes with thalidomide. Like Dr. Arora said, there's hydroxyurea has been given. So a lot of people use aspirin along with that. So what is your advice? And do you think, although I don't think we have looked at it formally, but does the malignancy risk, does it have anything to do with the drugs which are co-administered?
I don't think there is data available very easily on this, but I mean, my wisdom would say that why combine two such drugs, hydroxyurea and thalidomide? If one alone can be, effective, then why use another drug which has a overlapping adverse effect? And again, I mean, one can think of using in research setting if it minimizes the dose of either. If you are able to minimize the dose of, say, hydroxyurea to 5 milligram rather than 10, and you are giving 1 milligram of thalido. But then I think one has to study this. There
And
is
so
some
practice,
retrospective
yeah.
data available from our country using both the drugs and having good results in anti-DT. And some reports on TDT also with the use of both the drugs.
So that is our practical experience that if we combine, we can actually get away with much lower doses of hydroxyurea and thalidomide. So I think that is the rationale
Yeah,
that.
yeah. I think one important thing which is emerging out of this discussion is that we need to plan studies, and we can get this studies protocols reviewed by Madam Capellini or some other experts who are more senior and more, at least in research setting, they are working. So, and such protocols, and we should do our studies on these aspects.
If I can add a point, I mean, your experience is fundamental. I mean, is really, really very important for the use of thalidomide as well for hydroxyurea. What I really frankly suggest is design a proper clinical trial. Maybe treating a small number of patients, but with a clear primary endpoint, efficacy parameters, because we need, I mean, all the thalassemia community need this data. But having sporadic or let's say different approaches is not useful. So we never get the approval of the agency to use to reposition the drug.
Absolutely.
So my suggestion is really, really invest in designing a proper clinical trial.
Regarding this
Thank you, ma'am.
combination use, as sir said, I think that is the reason I combine, because I use thalidomide just 0.5 milligram to say per kg body weight, and hydroxyurea say 10 milligram per kg body weight. So that is the reason primarily I use combination. And this is that one study also published by Dr. Burani et al. Having more than say 150 patients, they have used as a combination, and results have been very good.
Yes, sir. Thank you, sir. So the gist of all of this is that it is a drug which is effective, but has to be used very carefully, and definitely requires a trial to get a recommendation or to an approval, the formal approval. Now we are really short of time, so we have 3 more drugs to discuss actually. So I'll be very, very brief. And so luspatercept is approved in India for above 18 years, as in the rest of the world, and phase 2 trials are going on. So Dr. Capellini, I think you already discussed it, and in your patients, I think the gist of what you told us, you're using it more for TDT compared to NTDT. And it was very interesting to see how you prioritize the drug even in a TDT setting.
But listen, we had the approval for TDT before NTDT. Frankly speaking, when we start to design the trial, I was supporting the use of in NTDT, but it was a requirement of FDA to work for TDT. So no doubt that I'm in favor of using it also in NTDT, with the precautions that we learn from the real life experience. But definitely I'm in favor of using it.
Thank you, ma'am. And Dr. Chandra, keeping logistics aside, what would you think, like 2-3 groups of patients who will benefit more from a drug like luspatercept?
I think all TDT patients who are not able to maintain hemoglobin, in the desired range, either because of the travel issues or non-availability, etc. And if the costs, as you said, are not an issue, they could be the candidates for, giving luspatercept.
Thank you.
And yeah.
Amita, ma'am, Have you used it in your practice, and what are the hindrances basically other than cost?
Our hindrance is mostly the cost, but yes, I've used in a limited way, both in TDT and in NTDT. It's a question of just discussing with the patient. The good thing is again that by 5 doses, you will get an idea of who will respond and to what extent. So again, my advice to anybody, if the cost was not an hindrance, I would consider offering it to all patients that, within a 3 month, 4 month period, you will actually get to know how much the drug can do for you. So at any point when they feel like giving this a trial, and even a 33% reduction is meaningful to them in terms of career or education or employment, then it can be considered. We've also used it in NTDT more in a way to get them off thalidomide and things. So, giving them a washout period for thalidomide and then introducing that drug. But numbers are too small for me to comment on the, response.
Thank you, ma'am. And Dr. Arora sir, as a patient advocate, would you like, there is a lot of support from Government of India for rare disorders and treating with expensive medicines. So do you think this could be a drug which can benefit patient through these such schemes?
I think I may differ here with the experts, because my experience is it is not much effective. Even I have seen the patients who have completed a trial of 16, 17 doses with zero effect, or even maybe out of 10 patients which are in directly contact with me, hardly one patient got a response of 33%. So spending so much money and getting it is not, I think, if you cost versus benefit you consider, I'm not in favor of this, frankly speaking. And if at all government has to spend, government should spend more money on giving the good quality chelators and this leukodepleted filters and this phenotype match blood NAT testing. If they if government spend that money on all these things, the patient will be much better than luspatercept. I may differ from the experts.
And I think we don't have experience also. So in the years ahead, probably we'll identify which is a subset. Thank you, sir. So coming back to the next question. So mitapivat, it came out few months ago, as in it was the news came out regarding FDA approval, and there was as any new drug which comes in a chronic disease community, there's a huge uproar about it. And mitapivat also received it, that it's going to be a big hope for patients. So if you look at the pyruvate kinase experience, I think the patients who have missense mutations are selected over the ones who have nonsense mutations or null mutations. So in a thalassemia group, do you think that patients who have milder disease benefit more, or is it similar for TDT and TDT? Dr. Capellini?
Yeah. Well, these are by thought that we don't have yet proof to supporting one subgroup of the other. Definitely NTDT for any new drug is the first target from my point of view, and definitely it is for mitapivat. Probably those who are less severe may respond more, because the mechanism is improving the quality of the red cells. So if I don't have a disaster, so if it is less severe, the outcome will be better. Nevertheless, I don't see limitation in selecting the patients. If I have a restricted use of the drug due to the cost or whatever, of course I will start from the milder form. In my mind, the combination of luspatercept and mitapivat will be the top, because you are improving effective erythropoiesis, then you improve the metabolism, and that's done. Of course, that's all dream and fancy things, but we have to keep in mind the cost. I totally agree with Dr. Arora. So we have to find the best for the patients, but also to consider the affordability. But anyway, for mitapivat, I don't see particular restriction.
Thank you, ma'am. And the dose used in pyruvate kinase and thalassemia, they're like very different, right? So what is the explanation for that?
It's just because of the need, because in PK deficiency, you are going to replace, let's say, an enzyme which is not functioning, is not present. In thalassemia, we have a wild type enzyme, so we need to strengthen the activity of the red cells, and for that we need, that was proven in preclinical study, we need a higher dosage. And that's why also there are an alert in the prescription leaflet for the liver toxicity, because we are using higher doses than in PK. So far, I had no any trouble with the liver in patients, in our patients treated, so I have no specific concern.
Thank you, ma'am. I think we'll skip this question, and so this brings in a lot of possibilities. As in, although it's not affordable currently, so would you think, like it has happened in say hemophilia care, the whole treatment has got revolutionized? Do you foresee such a future for thalassemia as well? I would request all the experts to come in. Yes, Dr.
So
Arora.
I think there is no reason to not be optimistic. We
Yes.
have to be optimistic, and if the for hemophilia there is another drug which is, I think, coming up. There are 3-4 drugs which are kind of rebalancing, and there's, I think, alternate 8 or something. What is the name of that new compound which is there for hemophilia? So similarly, research is going on, and we have 3-4 drugs now which are being talked about. So certainly there is a future for such drugs, and maybe the life for thalassemics also would be as easy as it is for the hemophilics.
Thank you.
Yes, Dr. Actually, I like to add that looking at the mechanism of action of mitapivat, I'm more optimistic. I think it will be more beneficial than considering luspatercept. That is the one thing. Secondly, since as Dr. Jagdish Chandra said, okay, now new drugs are coming, I'm sure the day is not far. We'll be having a drug which will increase hemoglobin, and maybe this BMT and gene therapy may become irrelevant. This is going to happen. That is, I'm sure.
Yeah, amen to that. And I think we are really we've run out of time. So I think I have just one question on ruxolitinib, because that's again a condition where we do have a lot of patients who have splenomegaly, hypersplenism. So I would request Dr. Amita to kindly
Just very briefly, we've had limited experience with ruxolitinib, and that's really stemmed from our morbid fear of splenectomy in these adults with, lots of other comorbidities. So I think in an attempt to avoid splenectomy, based from the data from the truth trial, and the primary endpoint for that trial was actually increase in hemoglobin, which it did not achieve, but they showed that a very large proportion of patients in the study actually had more than 1/3 reduction in the splenic volume. So based on that, we have used it in patients who are otherwise candidates for splenectomy, either based on hypersplenism or other issues. And we have seen that in those patients, we have been able to avert splenectomy. And most of the time we've used it in very low doses because they've already had cytopenia, and even at doses of 5 mg twice a day, which is much lower than the recommended dose for myelofibrosis, we were able to get reduction in splenic size, recovery of counts, which allowed us to give better chelation. Because they were neutropenic, they could not get the chelation. So very carefully, starting from low dose, we were able to get them to a point where chelation could be delivered effectively, and we averted splenectomy. And for most of them, after about a year of ruxolitinib, because that's again expensive, we took them off the drug, and the reduction, the spleen did not go bounce back to its original size, which was our fear. So in very selected situations, difficult situations, this is a drug that is now available to us. It may be carefully considered in a low dose. That's all I can add.
Thank you, ma'am. So I think we'll stop here from the panel part. And there are questions in the chat. We'll quickly see if we have not answered any. I think thrombotic risk. Do you want to comment, Dr. Arora?
Yes, I think I commented it that we are giving aspirin. Yes, I think.
Yeah, okay. And should we prescribe aspirin with thalidomide in pediatric patients? Is a question.
Yeah, I'm using over 10 years of age, so at that time I do prescribe. I don't give less than 10 years.
There's one question on how can we procure mitapivat in India. Amita ma'am, do you want to take it?
So it has to be currently imported with an import license through, there are specialized stockists that help us arrange for these patients, but the price is currently prohibitive.
Yeah.
And it would be more expensive than because we have to pay an import duty on that currently. So it would be even more expensive than what it costs in Europe or US.
Yeah. So I think for pyruvate kinase, this is like a couple of years ago. I don't know if the cost has come down. So at that time, I think 1 month's cost was coming to around 40,000 euros or so at that point of time. So I don't know how it is even.
Hopefully the company will lower the prices as soon as they are registered. We cannot accept that. I mean.
So just a small point I would like to make. In India, even some Ayurvedic medicines are being tried to reduce the transfusion needs. And currently, a candidate is doing PhD in All India Institute of Ayurvedic Medicine. She is looking at giving Ayurvedic medicine and looking at what it does to the whether it decreases the transfusion needs or not.
Yeah. Wheatgrass had come in between. Wheatgrass had come in for a bit 10 years ago.
No, they already have some experience in some kind of pilot work already. This is a PhD thesis being done. From there, I am co-supervisor of that thesis. So probably we might have some indigenous medicines also, which could be useful.
Thank you. So thanks again from my side. I would like to close the panel and hand over to Mrs. Tuli for the final remarks.
So thank you very much, Neeta, and thanks to all the speakers and especially the Dr. Nika Capellini, who has been here all throughout, and all the panelists, and wonderful discussions. And I think that 2 days ahead, we have the World Thalassemia Day. And I think it's a good topic that we had selected it. And I'm very sure there were a lot of patients and the parents that I saw on that. And I think more than 110 have joined. So I'm very sure that they must have listened and they will have more knowledge. So on one side, we are talking about a drug which is available, but the logistics and the price is the problem. On the other side, we have the 2 other drugs, which are cheaper in price, but the safety is the concern. So there is, I think, at this point of time, as Dr. Arora and many others said, that, well, it is better to concentrate on what is available and what has been tried, and what is good for our patients. At the same time, wait for the few years more where we have more experience on these drugs, and maybe we can come up like what we want is that the recommended treatment and the safe treatment should be offered to our patients. So thanks. I will take each one's name. I think Dr. Michael has already left, and Dr. Nika Capellini, Dr. Mita Mahajan, Dr. Yadav, Dr. Shweta, Dr. J.S. Arora, and especially Dr. Jagdish Chandra, who has been there all throughout. So you all have been my mentors and my teachers, and we all have to still learn a lot. In the end, I will just say that this year, the tips, this is for the civil society and for all of us. The slogan had been the hidden no more, finding the undiagnosed, and supporting the unseen. I think this speaks volumes about the roadmap, which has been set up by TIFF worldwide, and we have to follow it up. So apart from the treatment side, what we have discussed today and in the earlier session, the IAP program that we had. I think that we have to spread the message all across our country that prevention is the key to thalassemia control program. So early screening should be recommended, supporting THAL warriors, which is very, very important, advocacy for equitable care also, and especially eliminate the stigma, because if we go to the other parts of our country where the treatment is not there properly in place, and then of course is the promote the safe blood. So with these words, I would like to thank once again all of you, each one of you, and to all the participants, especially to Dr. Neeta Radhakrishnan, and another thanks to the ECO organizers for hosting this webinar. Thank you very much.
Thank you.
I want to thank you for inviting me. It was a pleasure to be with you. And thank you, Shobha. Hopefully, I will see you soon somewhere. Thank you very much.
We will meet soon. Thank you. Thank you very much.
Thank you very much. Bye-bye.
Small information from Dr. Shweta Bansal that the Indian Academy of Pediatrics is launching. In fact, it launched in an earlier meeting today itself, a thalassemia certification program through the Indian Academy of Pediatrics for pediatricians. So it's going to be a nominal charge of rupees 1,000 only. And that's going to be available as a course, as an online course. It will be coming up on the Indian Academy of Pediatrics website soon. So do share. In addition, a collaborative poster was released today. Mrs. Tuli was part of that event, where an online event, a collaborative poster with the Federation of Obstetricians and Gynecologists was released today, highlighting the importance of screening and to motivate and spread awareness among lay public as well as among gynecologists to screen for thalassemia aggressively. So these are two points which Dr. Shweta wanted me to.
Dr. Neeta, let me mention, that another news which I just received half an hour before from the Ministry of Health office is that you remember that we suggested them to put up the standees in the Kartavya Bhavan, which is the offices of the Health Ministry. So I have been told that, well, they're going ahead with that. So from 8th of May onwards, in celebration of World Thalassemia Day, there'll be a lot of standees put up in the Kartavya Bhavan corridors where people could come there and know about more. And secondly, which I mentioned earlier, is that 2 posters on to promote antenatal screening and for community awareness have been approved by the ministry and NHRC, and they'll be soon released. So thank you so much once again. Thank you so much.